We're now going to shift to our next segment, which is National Forum members and stakeholders sharing your experiences. Bobby is sticking with me. Thank you, Dr. Milstein. This is going to be an opportunity to hear directly from meeting participants who are their thoughts live on how the vital conditions framework informs, facilitates, and resonates with their work and initiatives. We have several participants who volunteered to share, and we're going to begin with Gladys Icaza Hunt, who is the Health Equity Liaison at the University of Tennessee Health Science Center. Gladys.
Thank you so much for giving me this opportunity. I was told I had like 60 seconds to share, so I'm going to make it really quick.
We'll give you 90.
Okay, well, thank you. So there's been a few things that we have been able to implement and been very successful recently, and so I wanted to share those. One is the implementation of somebody said earlier this morning about the neighborhood, that health happens in the neighborhood, and we have opened some neighborhood hubs where we are doing health coaching, connecting to care, and doing some screenings for the population. The other thing that we have been very successful in is that community and patient engagement. We are not only trying to do the patient outreach, but actually engaging the patient. And so we recently had an annual meeting where we brought in everybody from providers, health systems, to community-based organizations, to the patients themselves. And we had a panel with patients and what they shared. So we were learning and leaning and listening to the patients. I've also have heard throughout the day mentioning the mapping. We are working and have created a geospatial mapping that we have as a resource on our website, and we with resources that are out in the community, so that way that the people that are boots on the boots on the ground kind of have resources available to improve healthcare of that community. So let me see what else. I think we're working not only with the obvious partners in creating learning collaboratives, but we have really thought outside the box. And we even have organizations like the EMT and first responders joining us, because of course we know from a cardiac and health events, they're the first ones out there. So we are really working with them, in addition to the educational, to the school systems, particularly in Shelby County. So those are some of the biggest successes I think we have had. And I'll be staying for a few, for a little bit for Q&As after. And that's it for me. Thank you.
Thank you, Gladys. Very glad to hear what you're doing. All right, next up, we have Carla Alvarado, the Director of Research at the Association of American Medical Colleges Center for Health Justice.
Thank you so much for having me. I wanted to share that at the center, we view health equity as a destination and health justice as the path on that journey. And in our stride toward that journey, we plant one foot in community wisdom and multi-sector partnerships, and we plant the other foot on research to inform policy action. And so the Center for Health Justice was an early adopter and champion of the vital conditions, where Bobby Milstein and Dr. Philip Alberti have coincided at the National Academies, and I was able to meet them both there. And so since its inception, we welcome the vital conditions as a framework. Our center addresses several of the vital conditions, including belonging, civic muscle, a thriving natural world, and basic needs for health and safety. And one example of the way we incorporate the framework in our health equity and justice work is through our nationally representative public opinion briefs, where we anchor our findings in relation to the vital conditions. And so we aim to disseminate those conditions to our general public outside of the confines of academic medicine. And examples of the topics that we have pulled on are the public sentiment on trustworthiness, reparations, environmental justice, climate change, and civic engagement. And on these last two, climate change and civic engagement, we've incorporated the voices of the youth to the point that was made in the second panel, where it's important to pretty much foment that civic engagement muscle since early. So thank you so much. The framework has been very helpful to us in disseminating what we all aim to do, which is improve the health and well-being of the population. So thank you so much.
Thank you, Carla. Bobby, it's I can't think of many organizations who are more influential when it comes to healthcare system change than AAMC. So I don't know if you share that perspective, but it seems to me their work is really important as we're working to turn a very large ship.
Yeah, I mean, I have immense admiration for any organization that takes this personally in terms of how are we fitting into the bigger ecosystem and a bigger evolution of our understanding of this. The Center for Health Justice at AAMC is, from my view, is not only, asking some of the most relevant questions and gathering data, in answer to really frontiers of the field, but is also in a position to change the way we socialize new generations of people into this work. What do they need to be competent at? Trustworthiness is something to be built and earned. And so there's no accident that the skill sets and the research questions and the practice innovations policy that's coming out of that center is really helping to reimagine and reinforce what is the best of what this work can look like. We are very far from our best. And I just have great admiration for what Carla and Philip and the team, I mean, I don't know, thousands of collaborators really who are actively trying to find that path toward justice.
Thank you. Thank you, Bobby. Next up is a very good friend of the National Forum. I think someone who has participated in more National Forum meetings than I have, and that's Sunita Sonidodani, the founding director of the Center for Health Research at the Illinois School of Medicine, Peoria's campus, or Illinois' Peoria campus. There we go. So as I untie my tongue, please give us an update of what you're doing, Sunita, related to the vital conditions.
Of course. Thank you, John. It's always a pleasure at the National Forum. Before I give my 2 cents, I want to, to say 2 things. One is Julie has given me 2 minutes. Okay, so I'll take 2 minutes. And the second thing is I want to echo what Bobby said about AAMC and Carla, kudos to you. I also had the pleasure of working with AAMC team with Dr. Philip Alberti for developing the health equity inventory and then pilot testing the health equity inventory. So Eastern Virginia Medical School, my former institution, we were one of the 6 institutions that were involved in piloting the inventory. So kudos to AAMC. Again, thank you very much. I have moved here, John, as you know, in Illinois last year. And I think the topic that I'm going to bring up in the next, 60 or 90 minutes is very much aligned with the discussion that we had in the third panel, and that is the power of data and leveraging the data for improving health. And this is actually heart failure. So when I moved here, I think one of the major tasks of my center, which is a new center for health disparities called Center for Health Research. And the word "for" in my center basically represents informatics, analytics, population health, and health disparities. So we worked with 2 healthcare systems. OSF is the largest healthcare system, and the second is Carl Healthcare System. One thing that we observed, when I took the office, was the huge heart failure readmission rates. So what we have done is from the center two things. Based on the data of the last 3 years of all heart failure patients, and we have got the funding, we got the funding from OSF, we are developing an AI model that can predict high-risk patients who are at high risk for readmissions. So this model that we are developing, taking this 3-year data of all the patients who were discharged with heart failure diagnosis, we are collecting the information not only on the EMR records or claims data or pharmacy data, but we are also intervening to collect the social determinants. For example, information on literacy variables, social support, and all other those variables. The goal is to put this into the model and predict the 30-day readmission rates. And then people who will be at a high risk, they will be triaged to a more optimal, aggressive heart failure treatment. So that is number one. Number two, all these heart failure patients who are getting discharged, and before they get discharged, we are also making sure that we assess their mental health. So every patient before the discharge is gets a screening for anxiety and depression. And we give them GAT-7 and PHQ-9 questionnaires. And those who show the scores of anxiety or depression or both, they are directed to a cognitive behavior therapy program that is available here in the hospital care system. Online, it is called as Silver Cloud. So it's like killing two birds with one stone. Transition of care is a huge problem at many healthcare systems, and mental health is one of the complications of poor transition of care. So we are hoping that through the AI integrated predictor, we can identify high-risk patients, but at the same time, anxiety, depression, new cases of anxiety, depression due to heart failure, due to admission, can be directed to an online cognitive behavior therapy while they wait to meet their primary care physicians or their psychologist or psychiatrist. I'll be
Dr.
happy to put my...
Congratulations on that work. And it's exciting to hear how you're tying mental health together with physical health. And that ties us back to the observations that Bernd Melnick made during the first panel about the interplay between mental and physical health. And gosh, we know from what you just said, or even predating that, how closely tied heart failure outcomes and success in treatment is with mental health. So congratulations on that work. We'll be eager to hear about the progress.
I will put my link in the chat box. Thank you so much, John.
Thank you. Next up, we are pleased to have Shebra Hall, the Chief of the Bureau of Chronic Disease at the Delaware Division of Public Health. Ms. Hall.
Hi, good afternoon. Yes, it's Shebra Hall. We heard a little earlier from our Chief of the Bureau of Health Equity, one of my colleagues. So just thank you for the opportunity. I think I really can't say a whole lot more than that hasn't been said already. I just wanted to share that in Delaware, as Sequoia mentioned, as a state, we are at that point where we're ready to move to the vital conditions framework. And I think Dr. Milstein, you said it earlier in the first panel, we've been rooted in the social determinants of health, and we're ready to mature to that next level where we can roll up our sleeves and get some additional work done on how to address the social determinants of health. So that's kind of the frame that I'm coming from it at, is how similar the way that we're addressing our helping our population improve health outcomes. And in the Bureau of Chronic Disease, one easy example, of course, is looking at access to healthcare and comparing that to the basic needs as a vital condition. So obviously, we know how important access to healthcare is. However, we're taking that next step. And again, from the first panel where Dr. Saha eloquently put that we've embraced our journey through social determinants of health. And we have this shared vision. And now we're giving the opportunity to the community to lend their voices and how we can help improve cardiovascular health and improve other health outcomes. And again, Sequoia mentioned one of the activities in our Bureau of chronic disease around the learning collaborative that we just started this year. And we're really excited to move forward with that. And again, that's a perfect opportunity to hear from our community partners, our community members, and how we can improve health, cardiovascular health in Delaware. So I really just wanted to share how we have embraced the vital conditions framework, and we're using it through our social determinants of health lens now that we've matured in that phase. So thank you again for having us.
Catching fire, Bobby. All right, well, running the anchor leg of our relay here is our friend Meg Metter, who is the Director of Quality Improvement and Integration at NAC, the National Association of Community Health Centers. Meg.
Thank you so much, John, for this opportunity. And boy, I've really been challenged today in my thinking. So I thought I'm still going to do this. I want to share that NAC's work in cardiovascular health with community health centers has always been sort of rooted in the social determinants of health. As Shebra said, we develop our implementation strategies for evidence-based interventions grounded in that awareness and consideration for the social, economic, environmental circumstances of our patients. We recently concluded our Improving Blood Pressure Control in African Americans project, which included assessing basic needs such as food security and transportation, along with insurance and income status. And we tailored treatment approaches. So for example, we don't prescribe diuretics to somebody that takes 3 buses every day, learning those kinds of ways to be holistic in our care. And then of course, connecting patients with the community support services we needed. And we're excited to share that preliminary results show we were able to close the disparity gap in hypertension control in those participating centers. And then I wanted to also quickly share another more exploratory project we did with Alliance Chicago, which is a health center control network. We worked together to create a data model that brought together cardiovascular risk and social determinants of health data at the point of care, actually both for population health efforts and then also informing that holistic treatment. So as I'm excited to share those with you, I think as Jasmine said earlier, how can we do more and be better? And I think for NAC, a next step is really challenging ourselves and exploring how to leverage the vital conditions framework. So thank you.
Thank you, Meg. Well, yeah, not just Meg. Thank you, Meg. Thank you, Sony. Thank you, Shebra. Thank you, Carla. Thank you, Gladys. We appreciate your contributions. Bobby, Meg's last comment about how can we do more reminded me that in population health, where we frequently are confronted with the challenge to do more with less. And it seems like each year we have to do even more with even less. And I'm wondering if you've observed any changes in that dynamic with the vital conditions, that wondering do conditions help those of us doing this work draw in not only more partners and collaborators, but attract new or different additional dollars and resources.
Yeah, it's a great question, and I think I can hear the collective groan across the world when people say do more with less. It's like it's a joke, and it's often met with the response of I'm too busy to even get help. And so one of the things that this vital conditions framework helps us recognize is that the way we work and with whom matters significantly, right? If you start connecting your work with others and bringing more people who aren't feeling connected at all into it, feel like they belong, feel like their contributions matter, it actually amplifies, grows the pool of assets that allows us to be able to do more things. It's not with less. It's actually means by which we can do things that nobody can do alone. And that hasn't normally been visible or valued or investable, but the vital conditions framework is really sort of codifying insights from savvy practitioners going back, millennia really, but decades, that have shown that when you invest in genuine trusting relationships, when you expand that circle of who feels that they're part of it with an equity agenda, a racial justice agenda, suddenly assets are not the problem. It's really about the ability to coordinate, work well together, negotiate priorities, make investments that are going to yield even more investment. So the dynamics of growing belonging civic muscle are very modern too. It's one of those assets in the world. Like some assets, you can build a monument in one part of town and you don't have any money to build it on the other part of town. Belonging civic muscle doesn't work like that. The more you use it, the bigger it gets. It's part of the sharing economy. It's part of the other thing, a knowledge economy, right? And so that dynamic has been invisible to a lot of people who are thinking about transactional programs and projects. But if you're into movement building, then you already know that you're not doing more with less. You're doing more with more people and more talent, and we can accomplish great things.
Well, Bobby, you just said something that was very quotable. The way we work and with whom matters. That certainly is the case every day for the National Forum, not only because we're an organization of organizations, but we see the power behind what you just said, a very pithy comment. We see it every day, and it plays out in impact that is disproportionate to the limited resources that we and partners are able to bring to bear. So yeah, you're right, Meg, you're right about accomplishing more through collaboration. Gosh, there've been so many quotable comments throughout the day. In fact, we'll be making those available, and we'll be making not only recordings of all of the panels and Q&A segments available on the National Forum website in the next couple of weeks. We also will be making transcripts available. So if it's easier for you to find some of those great ideas or brilliant insights by using a transcript, that'll be available to you as well. So please watch your inbox, because you'll be getting a follow-up message from the National Forum letting you know that we've posted those resources and they're available not only to you, but to any of your colleagues with whom you want to share them. And we hope you will encourage those who weren't able to participate today to take in all these great learnings at the convenience of their schedules. So thank you all again for sharing how you are employing the vital conditions in your settings and how you're strengthening them. It's really interesting to hear that translational experience. Thank you all for your valuable insights. Your contributions really do enrich all of our understanding and provide us with inspiration to continue striving to improve fair opportunities for everyone to attain optimal cardiovascular health and good health and well-being wherever they live.